Hello, Dr. Nader, Dr. Sabri. Yes, I am Badawi. I will be the first presenter, inshallah.
Okay, great.
Assalamu
Thank you
alaikum.
for, yes, thank you very much.
Walaikum assalam wa barakatuh, Dr. Nader. Okay, Dr. Sabri, it's okay. I just need to share my screen first.
All right. Hello, everyone. Welcome to our Zoom meeting. So, Dr. Rayan and her team and Dr. Sabri will moderate the meeting. So, Dr. Rayan, when you are ready, you can start, share the screen, and the first topic will be about anxiety. Thank you.
Thank you so much, Dr. Nader. I'll start. I'll share my screen.
Go ahead.
Okay, thank you. Well, everyone can see my screen?
Yes.
That's great. Okay, so hello, everyone. My name is Rain Omar. I'm the team leader of the Orange One group. I'm so glad to be with you today, and I would like to thank Dr. Nader for this opportunity, and of course, Dr. Sabri and his team for giving me this opportunity to be part of their meeting today. So today's topic, the first topic that we will talk about is anxiety disorders. Me and my colleague, Dr. Amina, will talk about this important topic. We subdivided the topic into two parts. I will take the first part, and then Dr. Amin, inshallah, will talk about the pharmacological treatment of anxiety disorders in adults. So let's start with a question. Let's start with a question. The question is, have you ever felt so worried or stressed that it interfered with your daily life? Of course, most of us have faced stress at some point of their life, and it's totally normal to be overwhelmed about something in your life or about a stressful condition. But if you want to distinguish between the normal response to stress and the anxiety disorders, this will be a matter of how we respond to the stress. If our response was very excessive and persistent, and this response is just started to interfere with our daily activities and our life, and started to make a negative impact and impair our life, this could be considered a sign of abnormality, or we could say that it's a sign of something serious in which you need just to seek a medical attention. So this question, I would like to start with it, or I've already started with it, and then we can just go to the next slide, which is the anxiety disorders itself. So in order to define the anxiety disorder, we could say that an anxiety disorder is a group of disorders that affect the mental health, and it describes the excessive and persistent feelings of fear, worry, or nervousness, often without a clear reason. And once these symptoms started to appear, and it has a very negative impact in our daily life or daily activities or work or even relationships, it's considered to be an anxiety disorder. So I would like to highlight the huge impact of anxiety disorders. So the prevalence and impact of anxiety disorders in US, around 19% of US adults experience an anxiety disorder annually. That means there is a huge number of citizens or individuals who are acquiring the anxiety disorder each year, which just present the significant impact of this condition or this disease on population or US population. So these disorders significantly impair daily function and are often linked with other conditions like depression. Well, before diving deep to the subtypes of anxiety disorder, we should just try to know the causes of anxiety disorders. So it has a multifactorial triggers or causes, and stressful events, one of them, like exams or family problems. Genetics play a major role in the development of anxiety disorders, and of course the brain chemistry, I will talk about it briefly in the next slide, and the personality. Some people have the tendency to be naturally more anxious than the others, so they have the tendency to develop anxiety disorders more than the other people. Regarding the imbalance of the neurotransmitters, which were considered to be the cause of anxiety disorders, I would like to say something. Of course, all of you know that our brain contains different regions, and all these regions have different functions. For example, we have here in the temporal loop, in the medial side of the temporal loop, we have the limbic system. Limbic system consists of amygdala and the hippocampus. The amygdala is the place in the medial side of the temporal loop, which is responsible for the processing of emotions and fear. And the amygdala and hippocampus, both of them are responsible for the processing of emotions and fight and fear. So if there is any dysfunction in these areas in the brain, it could precipitate to the development of anxiety disorders. And we have here also the prefrontal cortex. Prefrontal cortex, it's an area that found in the brain, which is responsible for some cognitive function, behavior, attitude, and memory. If there is any dysfunction in this area, it could also predisposed to the development of anxiety disorders. We have also the neurotransmitters in the brain. Of course, all of you know that there is a different or a variety of neurotransmitters in our brain. Like we have we could say that we have the gamma aminobutyric acid, and we have something also called or a hormone called serotonin and norepinephrine. So they have found that if there is a decrease in serotonin and GABA neurotransmitters, it will predispose for the development of anxiety disorders. And if we have a high level of norepinephrine, which is a part of the sympathetic nervous system, if we have high levels of norepinephrine in our brain, it's also considered to precipitate for the anxiety disorder. So in the context of neurotransmitters, or in the term of neurotransmitters, yes, imbalance in some neurotransmitters and hormones and some areas in the brain. If there is any dysfunction of these areas, it could be predisposing to the anxiety disorders. Well, let us come to the types of anxiety disorders. Just let me to do something here, sorry. So we have subtypes, or we have main types of anxiety disorders. We have panic disorder, agoraphobia, specific phobias, social anxiety disorders, generalized anxiety disorders, obsessive compulsive disorder, and post-traumatic stress disorder. All of these subtypes we will we will dive deep to express or to explore each one of them in the next few slides, but these are the main subtypes of anxiety disorders. Before diving deep to the sub-classifications of anxiety disorder, we should know that we have to do a very good assessment for the patient in order to diagnose anxiety disorders. The assessment and evaluation are very important to come up with a specific or appropriate diagnosis to the clinical condition. So in order to do the assessment and evaluation, the physician should conduct a clinical psychiatry interview. There must be an extensive clinical psychiatric interview or history taking. So the physician should ask the patient about the symptoms, the onset of symptoms, the duration, and if there is any other condition that or symptoms associated with the symptoms of anxiety. So the clinical psychiatric interview is very important and should be done first in order to help the physician to reach an appropriate or a proper diagnosis. Mental status examination, it's very important in the context of anxiety disorders because you need to examine the mental status of the patient, their behaviors, their emotions, if there is any changes, because it can help you also to reach into an appropriate diagnosis. The social context and support. Of course, you need to ask about the family support, friend support, because people with anxiety disorders who have the social and family support, friend support, of course, they can cope better with the symptoms of anxiety disorder. And of course, we have the medication review. In the medication review, we have multiple things because, of course, in the medical field, all of you know that there is certain medications or specific medications associated with the development of anxiety symptoms. One of these medications, of course, like steroids. Steroids could have a side effect that could be presented with anxiety symptoms. So steroids, CNS stimulants, of course, like caffeine and other drugs that act as CNS stimulant, it could present with the symptoms of anxiety disorders. So we have multiple drugs that could present with the symptoms of anxiety disorder. So we have carefully made a very comprehensive medication review in which we can just identify if there is any drugs or any medication that have been received by the patient and these symptoms is associated or related to these drugs. And of course, the laboratory test, yes, laboratory tests are very important because there is some medications some medical conditions could be associated with the symptoms of anxiety disorder. The famous one is the thyroid. So laboratory tests could includes the TSH, because TSH is associated, if it was very low, it could be associated with hyperthyroidism, and hyperthyroidism could be presented with anxiety symptoms, restlessness, irritability, and all the things. And of course, glucose itself in acute setting, because also hypoglycemia could present with restlessness and irritability, and electrolytes dysfunction, maybe magnesium, maybe sodium, all these electrolytes, if there is any imbalance of these electrolytes, could present with the symptoms of irritability and anxiety symptoms. And the last one is GAD, Generalized Anxiety Disorder 7, which is a simple questionnaire that contains multiple questions, or 7 questions, to assess the symptoms of anxiety disorders in the previous 2 weeks. It's used to assess the patient or the individual and their symptoms in the term of anxiety disorders. If their symptoms were mild or moderate or even severe, it has a score inside it, but it's used to assess the symptoms of anxiety, and then it helps to classify these symptoms if they were mild or moderate or severe. So the clinical assessment and evaluation is very important in patients with anxiety disorders, because we have other causes for anxiety disorders, so you need to search for it. Well, we will start with the panic disorder, the first one. So we will start with the panic disorder. Well, panic disorder is one of the anxiety disorders, and it's characterized by recurrent and unexpected panic attacks. It's usually comes in episodes. There is episodes of intense fear or discomfort, and symptoms must include at least 4 of the following. All these symptoms, 4 of them must be presented in a patient in the episode at least for 1 month in order to diagnose panic disorder. So we have these symptoms, which are palpitations, sweating, trembling, shortness of breath, choking sensation, chest pain, nausea, dizziness, chills, or hot flashes, feelings of derealization or depersonalization. Derealization, it means that the patient or the individual will be disconnected from the reality. They feel that they are like in a vivid dream, or they are in a dream, not something real. And depersonalization, they will be disconnected from their own selves. They could feel that they are out of their bodies, or their bodies don't belong to them. So this is the derealization and depersonalization. So in panic disorder, the episodes, it occurs in episodes, and these episodes must contain at least 4 of these symptoms in order to be considered as panic disorder. And these symptoms should occur at least for 1 month. And the attack itself, it stays at least for 10 or 30 minutes. So the panic attacks typically last for 10 or 30 minutes. And the diagnosis requires persistent worry about future attacks and significant distress for at least 1 month. Yes, that's true. So the panic attack itself, it will last for 10 to 30 minutes, and we need the symptoms to be at least for 1 month in order to diagnose panic disorders. And they have something also very special in panic disorder, because usually there is no trigger. The patient just will develop the symptoms suddenly and immediately, and there will be no specific trigger. So they have always been struggling, or they will be very frightened to develop any attack in any place because there is no trigger. They can develop the attack in any place. So their main concern is to develop the attack in any place, and they don't know what to do. So the excessive fear of developing the symptoms suddenly without any trigger is a major concern for them, and it's associated with panic disorder. And in older adults, symptoms are often more limited, involving specific organ systems, and commonly associated with other medical or psychiatric conditions, particularly in adults or elderly patients. So the second anxiety disorder is agoraphobia. Well, agoraphobia, I will talk about the agoraphobia and then the specific phobia. So agoraphobia and specific phobia, they have similarity between them, because in both of these conditions, the individual or the patient will be afraid or have a concern, or the patient will be frightened to be exposed or encounters a specific object or specific situations. For example, in a specific phobia, it's more easier than the agoraphobia. In specific phobias, usually there is intense, persistent, and excessive fear of a specific trigger, like animals, heights, or even flying. So the patient will be very frightened to encounter or to be exposed to a certain object or situation. And the anxiety arises immediately upon exposure to the trigger. Once they are exposed to animals or to heights or to flying, the symptoms started to appear immediately. And in the specific phobia, usually the patients recognize that the fear is irrational, but they cannot control it. They cannot control these symptoms. So specific phobia could be for specific triggers like animals, height, and flying. We can see here. I'll return back to the agoraphobia, but I wanted to say the specific phobia because they are similar to each other. There is just some differences in the agoraphobia. So the specific phobia, as I mentioned before, the patient will just be afraid of certain object like or animals. Maybe here the patient is very frightened from snake, maybe from spiders, maybe from cockroach, maybe from dentist, anything, a specific thing or a specific situation that they are afraid of. But in agoraphobia, it's also a type of phobia, but it's just more complex than the specific phobia. There is a fear of two or more situations. So agoraphobia is associated with fear of situations in which the patients are very frightened and afraid to be in a situation that they cannot reach for help or be provided by help. So in these situations in which the patient is just cannot reach a help, they will be panicked and freaked out, and they will feel all the symptoms of anxiety. So agoraphobia, it's more complex than specific phobia because it contains more situations of these things, which is the patient could be afraid of public transport, open or enclosed spaces, crowds, or being outside alone. All these situations, the idea behind it is just they are so afraid to be alone and they cannot reach out for any help. And it's linked to fear or panic of embarrassment also because they will be alone and they don't know what to do when they are alone. And the persistent response is causing significant distress or impairment. Actually, this concept is applied to all types of anxiety disorders. Once the anxiety disorders started to interfere with our daily lives and to interfere or make a negative impact or make a huge impact or decline in our functions, it's considered to be an anxiety disorder because it interferes with our daily activity. So it's applied to all types of anxiety disorders. So the agoraphobia is more complex than this specific phobia. As you see here, this patient who is outside, he is feeling terrible, or he's so frightened because he's outside alone and he doesn't know the thing that he doesn't know what to do. So this considered as agoraphobia. If you can notice here, or if you can see here, this young lady who is inside an enclosed space or place, she is frightened and she's freaking out, but I could say that this patient could have agoraphobia if she is so scared to be alone and not find the appropriate help or to reach out for help. But if this patient is having like she is so frightened, or she is afraid from being in an enclosed space, only like just being in a closed elevator like this, and she is so scared because she doesn't like to stay in enclosed spaces just like this without feeling frightened that she could not have help or no one will reach her. This could be a specific phobia. It's called claustrophobia when people have concerns, or they are so frightened from staying in enclosed spaces. And of course, also I said here, or you could notice here, the agoraphobia, as I mentioned, it's fear of two or more situations like public transport, open or enclosed spaces, crowds. Maybe they are also afraid from crowds. Also, they cannot find or reach out for help, and being outside alone, as I mentioned, of course. Also, we have discussed the specific phobia. As I said, all these subtypes of phobia or specific phobia. Some people, yes, feel afraid from dentist, from cockroach, or even spiders. Well, my personal story that I have a phobia from snakes. I don't panic out from the spiders or cockroaches or all the things, just the spiders. So I guess it's something common. The phobias, I guess anyone of the audience right now could have like some sort of specific phobia. Well, going to the first type of anxiety disorder, which is social anxiety disorder. Well, social anxiety disorder could be considered as a type of phobia. There is a similarity between it and the initial or the original phobias, because at the end, social anxiety disorder, it means that the patients will be afraid of interfering with others, or they are afraid of public situations. So fear of behaving inaptly or awkwardly or embarrassingly in public. Usually those people will have the concern that the other people could judge them, or the other people could criticize them. So all the time they are afraid of the criticism by the others or the judgment by the others. So they could feel trembling, blushing, sweating in social events. The common triggers is public speaking, socializing, or dating. Some people have social anxiety disorders. It's called performance type. It's when you are trying to present something or do something in front of people, and the other people should evaluate you. It's called social anxiety disorders performance type. And people say that whenever I start to present, I feel butterflies in my stomach. So it's the feeling of trembling, blushing, and sweating in front of people. So the common triggers, as I mentioned, public speaking, socializing or dating, eating in front of others, or using public restrooms. Well, eating in front of others, it's usually associated with elderly people, because with time, elderly people will start to develop decline in their function due to aging process. So they will feel like they are so embarrassed in eating in front of the others if there is any functional impairment of their skills, or they have lost some of their skills due to aging process. So eating in front of others or using public restrooms in older adults, yes, embarrassment about physical decline. Yes, that's true. They will be embarrassed about the physical decline, and they could feel embarrassment. Now we are coming to the fifth anxiety disorder, which is generalized anxiety disorder. Well, the JAD is more broader conditions in which there is a distinctive symptoms that found. There is the symptoms of the psychological symptoms of anxiety plus the organic symptoms or the physical symptoms. So we have distinctive symptoms like excessive anxiety and worry, easily fatigued, muscle tension, difficulty sleeping, difficulty concentrating, irritability, or feeling on edge. Well, regarding the generalized anxiety disorder, the DSM-5 Diagnostic and Statistical Manual of Mental Disorders, 5th edition, they said that the patient should acquire like 3 or more of these symptoms at least for 6 months. It's more chronic condition, so the condition must be must be found at least for 6 months, and these symptoms must have, the patient must have 3 or more of these symptoms in order to diagnose generalized anxiety disorder. And generalized anxiety disorder, from its name, it's generalized. So the patient will feel excessive anxiety and worry about multiple aspects of their life. Maybe they will be so afraid and worry about their family, maybe about their work, maybe about their social interactions. So they have multiple aspects of multiple aspects that are so concerned about, or they are so anxious and feels worry about. So as I mentioned, yes, the diagnosis requires having 3 of these symptoms at least for 6 months in order to diagnose generalized anxiety disorder. Coming to the part of to the 6th part of anxiety disorder, which is obsessive compulsive disorder. I guess most of you know this condition, in which obsessions are persistent and intrusive thoughts, often during specific task or situation. And the compulsions are the actions or the specific action that they have been done by the patients in order to decrease their anxiety. For instance, if someone feels that the germs are spread everywhere and he's so scared to acquire any infection or any disease. So the person, in order to decrease these anxiety symptoms, he will start to do actions. These actions or behavior he's doing, he knows that it's irrational, but he's doing it to decrease the anxiety of the intrusive thoughts or the persistent and intrusive thoughts. Like if as I mentioned, if someone thinks that the germs are spread everywhere, he will start to wash his hands over and over, repeatedly, in order to decrease his anxiety. So the obsessions are the thoughts or intrusive thoughts, and the compulsions are the acts or behaviors that used by the patient or individual in order to decrease the symptoms of anxiety. So the key points here are that these symptoms are often disabling. Yes, it interferes with their daily activities, and it can impact their function, of course, as I mentioned earlier. All the subtypes of anxiety disorders, in order to consider them as anxiety disorders or diseases, should have the association with significant impairment and declining of the functions of the patients. So yes, I said often disabling. New onset in late life is rare. Yes, it's usually started early in life and commonly linked with depressive syndromes or early dementia. Well, we have come to the 7th part, or 7th anxiety disorder, which is post-traumatic stress disorder. Well, post-traumatic stress disorder is the situation that occurs when someone is exposed to a major event or a very stressful event, like the wars, like someone lost someone who is very close to him, one of the family members, a very close friend, maybe a huge accident or a massive accident in which he was seeking for help and he couldn't reach it. So usually the post-traumatic stress disorders, it occurs after a major event or a major stressful condition. And well, they have many symptoms or common symptoms. The common symptoms of post-traumatic stress disorder is re-experiencing the traumatic event. Usually those people will start to experience flashbacks and nightmares about that specific condition, and they are trying to avoid every stimuli that could just remind them with this stressful condition. They will try to avoid the places or even the people that could just remind them with this stressful condition. There is also psychological numbing. Psychological numbings mean that they will start to be disconnected emotionally, and they will face difficulties in making relationships or to be engaging in an emotional process. And they will be hyperarousal, of course. They will be difficulty sleeping, hypervigilance, or even exaggerated startle. Maybe if someone just slapped the door strongly, they will start to feel frightened and they will just be very concerned about that. The diagnosis of post-traumatic disorder, the patient must be exposed to a traumatic event, of course, with fear and helplessness, as we mentioned, traumatic event with fear and helplessness. And the symptoms should last at least for 1 month, because you know that if these symptoms of traumatic stress disorder, the common symptoms, last for less than 1 month, it's called acute stress disorder. It's not post-traumatic stress disorder. And of course, significant distress or functional impairment, as I mentioned, all the anxiety disorders should be associated with significant distress or functional impairment in order to be considered as anxiety disorders. Okay. Okay. So I guess we have been discussing the main subtypes of anxiety disorders, and we come to the depression with marked anxiety. Well, in this slide, I could say that some people or some elderly patients could have depression symptoms, but they cannot say that. They cannot disclose the symptoms of depression. There is some cultures that believe that these symptoms considered as not good, so they cannot express themselves and say that they have symptoms of depression instead they are just saying that they are so anxious, or they can easily say the symptoms of anxiety, but it's very difficult for them to express the depression symptoms. So anxiety is a prominent symptom of depression in older adults. Anxiety may be more culturally acceptable than depression in this group. That's true. So the most important message here is you should evaluate for major depressive disorder in patients with anxiety complaint, because maybe they are explaining or they are expressing the anxiety symptoms, but the real thing that they have depression rather than anxiety, or maybe they have the two conditions together as coexistent symptoms or coexistent conditions. Well, we can also come to talk about the anxiety and medical disorders. Of course, the anxiety symptoms could be due to psychological or psychiatric conditions, as we mentioned in the previous slides. But also it could be associated with medical disorders, because all of you know that in our medical field, there is some situations or some diseases that are associated with symptoms that's very similar to anxiety. So medical illnesses can mimic or worsen anxiety disorder. So like the common conditions that could be associated with anxiety disorders or even present with anxiety disorders is COPD. So patients with COPD or cardiovascular diseases could present with anxiety symptoms like irritability, restlessness, shortness of breathing, and all the things. And maybe these conditions could precipitate for the anxiety symptoms and vice versa, of course. So the COPD and cardiovascular diseases could present with anxiety symptoms, and if they are already present in a patient, could precipitate the symptoms of anxiety. And the hyperthyroidism, of course, all of you know that the thyroxine, the hormone that found in our body and produced by the thyroid gland, if it was so high in our body, it will stimulate our CNS, and it will lead to the symptoms of irritability, restlessness, anxiety symptoms. So yes, hyperthyroidism could be associated with anxiety symptoms. And sometimes infections like respiratory infections, cold or influenza. Yes, cold and influenza could also precipitate the symptoms of anxiety, or it could present with symptoms of anxiety itself in elderly patients. And we have medication side effects, as I mentioned earlier, that some medications could have a side effect that mimic the anxiety symptoms or anxiety manifestations or presentations. Of course, angina and myocardial infarction could present with symptoms of anxiety, or it could precipitate the anxiety symptoms that have already existed in some patients. So thorough assessment, including clinical history, is essential before treatment of anxiety disorder, because as you know that for the previous slides, the anxiety disorder could be caused by all these 7 main subclassifications of anxiety disorder, or could be associated with medical conditions, or it could be due to a medical condition. Well, as we have seen, anxiety disorders are complex and they significantly impact daily life, but they are treatable with right approach. So in order to treat the patient in a very good approach, we should understand anxiety as the first step. So as a first step to treat an anxiety disorder, we should understand it. And the understanding of anxiety disorder is very good, both for those who are suffering from anxiety and those who are helping them on their journey to recover. So I guess I have come to the end of my slides and my presentation. I will close my presentation with these two quotes because they are so inspiring. The first quote says that nothing in life is to be feared, it's only to be understood. Marie Curie. And you don't have to control your thoughts, you just have to stop letting them control you. Dan Millman. So now that we have explored the nature, I guess, of anxiety disorders and its connection to the other medical conditions, we can just turn to how we can address these challenges or through pharmacological and psychological treatment. And this will be with my colleague, Dr. Amna. So thank you so much, everyone.
Assalamu alaikum. Thank you, Dr. Ryan, for the amazing presentation. I'd like to continue. Can you see my screen?
Yes, Amna, we can see it.
Okay. First of all, I would like to give credits. This presentation is from the GRS teaching slide. Okay, so my name is Amna. I'm from the Indigo One team. I'll be continuing the presentation from the pharmacological management, inshallah. Okay, so Dr. Ryan discussed a lot of disorders, and I'll go briefly through the some of the treatments that are used. As we all know, a lot of the treatments are interchangeable, or you would find treatments in psychiatry that are used to treat multiple disorders, as we can see from the table. For panic disorders and agoraphobias, the first line treatment is usually SSRIs, selective serotonin reuptake inhibitors. The serotonin norepinephrine reuptake inhibitors could also be used, and cognitive behavioral therapy, which is CBT, is also used as adjunct therapy. The second line treatment, or the adjunctive therapy that could be used in panic disorder and agoraphobia, are benzodiazepines. For social anxiety disorders, again, SSRIs are used. They're, in general, the preferred first-line medication in anxiety disorders and in major depressive disorders as well, both in young patients and older patients, but also in older patients, they're preferred. Plus cognitive behavioral therapy. And benzodiazepine comes in second for the second-line treatment. Social anxiety disorders and specific type disorders like for public speaking and so on, beta blockers can be used, but it's off-label use, and cognitive behavioral therapy is the first-line treatment. Buspirone can be used as a second-line treatment or an adjunctive therapy. For specific phobias, cognitive behavioral therapy can be used, or benzodiazepines could be used BRN, so they could be used when in need, not in a regular dose. For the second line of treatment for specific phobias, SSRIs can also be used. For obsessive compulsive disorders, the first line would be SSRI, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors, and cognitive behavioral therapy. These are all at the first line of treatment. Second choice for treatment or adjunctive therapy could be clomipramine, which is not preferred because it has multiple adverse effects in older adults. Okay, so for the post-traumatic stress disorders, again, SSRIs and SNRIs in the first line, second line treatment, cognitive behavioral therapy, and brazosine. For generalized anxiety disorders, selective serotonin reuptake inhibitors, as well the SNRIs and the cognitive behavioral therapy, in addition to relaxation training. As you can see, most of the those disorders have similar treatments. The second line in generalized anxiety disorder is benzodiazepine. For the anxiety and other medical disorders, you could identify and treat the underlying cause. For example, if the anxiety is caused by a comorbid condition, you can identify and treat the underlying cause. You can also use SSRI or SNRI if the patient is found to have a primary anxiety disorder. Second in line, again, is benzodiazepine. It's not very preferred to use it in older patients, but we will talk about that in details in the following slides. For depression, when the patient has depression with severe anxiety, again, SSRIs and SNRIs and cognitive behavioral therapy come in the first line of treatment, and we can use buspirone and benzodiazepine. Now, as a rule of thumb, while choosing a pharmacological agent, it's always to prefer the rule of start low, go slow, and titrate up to usually half of the adult dose. Okay, so regarding the antidepressants, which are the selective serotonin reuptake inhibitor and the serotonin norepinephrine reuptake inhibitor, those are the SSRIs and SNRIs. The SSRIs are the relatively favorable ones because of their favorable side effect profile, and they are the drug of choice for panic disorders, obsessive compulsive disorders, generalized anxiety disorders, post-traumatic stress disorders in younger patients, and depression with severe anxiety. So because of their favorable side effect profile, they don't have a lot of concerning side effects. They are the first choice of medication for those disorders. Now, it's advisable to continue the treatment for 4 to 12 weeks. The period is longer, of course, for OCD and PTSD. And this is advisable to continue treatment for this period of time before a response is expected. Okay. Choose a short-acting agent. Okay, so next slide, we'll be discussing in this slide benzodiazepines. It's important to choose a short-acting agent excuse me. Okay, for benzodiazepines, it's important to choose a short-acting agent without active metabolites, such as lorazepam or oxazepam. You can also, it's important to limit the use to less than 6 months, and long-term use of benzodiazepines in elderly patients is fraught with multiple complications, such as motor incoordination and falls, cognitive impairment, and depression. It also has a very concerning potential for abuse and dependence. The elderlies in general are quite sensitive to benzodiazepines, which already has a neurocognitive effect that's similar to alcohol, regardless of whether it's used in elderly or younger patients. So used with caution. Their use can also cause paradoxical agitation. Hence, as far as possible, they should be avoided. And when required, the doses should be low and they should be tapered quickly. So benzodiazepines in general are not preferred in elderly patients. Now, going off to buspirone, studies suggest some efficacy in treating generalized anxiety disorder with buspirone. However, clinical experience has been less positive. It does appear to be safer than benzodiazepines for patients taking several other medications or needing treatment for longer periods of time. So because elderly patients generally they usually tend to have a lot of medications they take in polypharmacy. So it can be used in that case when a patient is taking a lot of medication and they should, not should, but if a doctor is trying to avoid using benzodiazepines, if the patient needs to use the medication for a long period of time, they can prescribe buspirone in that case. Clinical response is delayed for about 4 weeks. So you can start by a concomitant use of short-term benzodiazepines while the buspirone is taking action, because it usually gives a response after about 4 weeks. So starting with the short-term benzodiazepines and then continuing for the long-term with buspirone. However, both agents are not first line of treatment in most of the anxiety disorders, and it would be preferred to use SSRI. Okay, so let's move on to other drugs that are also not recommended. First off, we have antihistamines. Antihistamines are sometimes used for mild anxiety. Even though there are few data demonstrating their efficacy, their anticholinergic effects can cause serious problems in older adults, so they are not recommended to use in older adults. The second generation antipsychotics are also not recommended choices for treatment of non-psychotic older adults with an anxiety disorder. So if the patient is non-psychotic and they have their only issue is an anxiety disorder, it's not recommended to use second generation antipsychotics. Okay. Psychological management. Now, first I started by discussing briefly, obviously, not in much details. I discussed the pharmacological treatment. The other wing, if we can see these the treatment consisting of two wings, a pharmacological wing and a psychological wing. If you picture a bird that we're trying to fly, we would say that an important side of the treatment, or an important aspect of the treatment of anxiety disorder or psychiatric disorder in general, is the psychological management. Now, as you could remember from the table I showed in the beginning, most of the disorders were treated by cognitive behavioral therapy, that's CBT. The psychological management in general, whether it's cognitive behavioral therapy or not, are often efficacious. They're often efficient, either alone or as an adjunct therapy to medication. We'll talk specifically about cognitive behavioral therapy, which has been the most rigorously tested technique, and the techniques of cognitive behavioral therapy fall into 3 categories. First of all, we would have relaxation training, which basically, as the name suggests, you train the patient to relax. It could be used. It could be done using music, visual imagery, aromatherapy, or you could teach the patient instructions in how to relax, breathing techniques, and so on. The other technique that's used in CBT is cognitive restructuring. As the name suggests, you try to restructure the cognition of the patient, how the patient thinks and reacts about certain things and how they respond to certain triggers and so on. The third technique is exposure with response prevention. This is particularly beneficial and effective for treatment of obsessive compulsive disorder. As the name suggests, you expose the patient to a certain trigger and then you prevent the response, basically to make the patient, so that you get the patient used to not responding to the trigger in the same way. So, for example, to give again the example that Dr. Rayan gave, which is a patient who is extremely afraid of germs. They think that if the germs are everywhere and they're going to get an infection, if you can try to expose the patient to certain thing, for example, touching a doorknob, for example, or touching a chair or anything, and then instructing them not to immediately wash their hands 10 times, for example, with soap, so that they get used to not always responding to the trigger. Okay, so in summary, I would say that late life anxiety is often comorbid with other problems, such as cognitive decline and depression. Comorbid medical problems commonly lead to anxiety disorder include cardiovascular and pulmonary disorders. The SSRIs, or selective serotonin reuptake inhibitors, are often used as first-line treatment for anxiety in late life. The pharmacological, so SSRI are first-line treatment. Often they're the first-line treatment. Non-pharmacological therapies may be helpful, particularly for generalized anxiety and anxiety secondary to medical conditions. So if a patient has anxiety that's secondary to another medical condition, you either treat the medical condition and do a psychological or non-pharmacological therapy, or you just treat the medical condition. Obviously, all of this depends on what disorder does the patient have, because you personalize this to the patient, to the drug that they responded to, which drug did they respond to well, how much can the patient handle. For example, did they take SSRI and have a side effect to it? So you need to, or maybe it did not give a response after waiting for 4 to 12 weeks. So in that case, you would need to explore the other options that we said, such as buspirone or benzodiazepines, with caution, obviously. Okay, so allow me please to give you this case. I will only be discussing this case, inshallah. And so an 82-year-old woman has had increasing anxiety and worry for 8 months. She says she sleeps poorly, she's tired, and has had generalized aches for several weeks. She is accompanied by her daughter, who states that the patient consistently worries about her grandchildren and her husband. After checking her thyroid and other basic medical review, generalized anxiety disorder is diagnosed. So this patient is 82-year-old, and after the medical screening, it's found that she doesn't have any medical condition, and she's diagnosed with generalized anxiety disorder. The question is, which one of the following is the best treatment option for this patient? Do we give her benzodiazepines and cognitive behavioral therapy? Do we only give her cognitive behavioral therapy? Or do we give her selective serotonin reuptake inhibitor and cognitive behavioral therapy? Or should we give her only selective serotonin reuptake inhibitors? What do you think? Okay. Does anyone have an answer? Does anyone want to contribute? Yes?
C?
C, yes, excellent. C. So we would give this patient selective serotonin reuptake inhibitor. Thank you. I cannot see the name of who's talking, but thank you very much for your answer. This patient is elderly, so it would not be advised to give her benzodiazepines, specifically at the start. So we would start with the first choice, with the safest option. That's not technically the safest, but the one with the most favorable side effect profile, which is the SSRI, and in addition to that, the cognitive behavioral therapy. Okay, there is another case, but I would like to stop at this one. I would like to give credits for the authors of this presentation because I did not prepare it myself. And I just want to say that I did make some tweaks and edits to the presentation. Thank you, everyone. Please feel free to ask me if you have any questions. And thank you, Dr. Rayan, for the very amazing and visually pleasing presentation. Thank you very much, everyone. Thank you, Dr. Nader and Dr. Sabri.
Thank you so much, Dr. Amna, for this presentation. Thank you so much. If anyone has any question, feel free to ask. Don't hesitate. Me and Dr. Amna are ready.
Yes, thank you very much, Dr. Ryan and Dr. Amna, for the great presentation. It was very informative, comprehensive, and you got it to the point. Actually, this is the best anxiety disorder presentation I have ever seen. So thank you very much once again. If anyone has any questions, we would like to have them now, or we can move to the next presentation, which will be the research bias by Dr. Walaa Al-Hadi.
Everyone, can you hear my voice?
Yes, we can.
So please share the screen.
Yes, I'm sharing it now. Can you see it now?
No. Yeah, of course. So first, I want to thank you, Dr. Nadir, for giving me this opportunity to be part from this program. And I'm so happy and excited for this. So my name is Walaa Hadi Ahmed Abdullah. I'm second year medical student in International University of Africa, and I'm from Blue 2 team. So next, please. So I will present for you research bias. So error. Error is deviation from truth. Next. Types of error, we have random error and systematic error. So random error is a chance difference between the observed and true values of something. So this error can be solved by repeating the measurement multiple times and take the average values. Systematic error is a constant proportional difference between the observed and true values of something. And this type of error is affected the internal validity of the study and is unacceptable error. Next. Next, please. So systematic error, which is bias. So bias can occur at any stage of research in planning, implementation, analysis, or application. Next. So types of bias, we have several types of bias, such as selection bias is a distortion in a measure of association, such as a risk ratio due to sample selection that doesn't accurately reflect the target population. Next. So example for selection bias in a case control study of smoking and chronic lung disease, the association of exposure with disease will tend to be weaker if controls are selected from a hospital population because smoking causes many diseases resulting in hospitalization than if controls are selected the community. Next. Also, we have self-selection bias. So self-selection bias occurs when you let the study participants select themselves to join the study group. Example for this, questionnaire was sent to doctors by email to all doctors in the hospital to assess the impact of workload on their anxiety and depression. This questionnaire is likely to be filled and submitted by doctors who have free time to access their emails. So doctors who are present in the workload of the clinic are likely to be excluded from this study or from study. Next, please. So also we have reporting bias. So reporting bias occurs where the authors tend to report some outcomes and hide other outcomes. So examples for this, reporting statistically significant outcomes and not reporting non-significant outcomes. Also measuring several outcomes and reporting favorable outcomes only. Also reporting the planned outcomes using an assessment tools or scores other than planned per protocol. Next. Also, we have recall bias. So when the patients don't remember previous events or experiences accurately, and this bias is problem. particularly in studies that have self-reporting like retrospective cohort studies or case control study. Next. Also, we have detection bias. So differences between two groups in outcomes measurement, such as outcome assessors might unintentionally overestimate or underestimate patients' outcomes during the assessment in the experimental or control groups. Next. So also we have zero time bias. So this bias when the study participants might be exposed to the risk factor at different time points. Example for this, in prospective cohort studies that assessing the impact of smoking on the risk for lung cancer, participants have started smoking at different time points. So the difference might be source of bias. Why, if the outcome of interest is affected by the duration of exposure to the risk factor. Next. Co-founding bias. So co-founding bias is a problem resulting from the fact that one feature of the study subject has not been separated from a second feature and has thus been co-founded with it, producing a surprise result. The surpriseness arises from the effect of the first feature being mistakenly attributed to the second feature. So example for this, a study found alcohol consumption to be associated with risk of coronary heart disease. However, smoking may have co-founded the association between alcohol and coronary heart disease. Next, we have attrition bias, is systematic differences between people who leave the study and those who continue can introduce bias into a study's results. So, such as a study of psychosocial factors among patients with cardiac conditions showed that those who fully completed the study differed in clinical and psychosocial features from those who dropped out before the study ended. Such differential attrition could have biased the study's results. Next. Any question? So thank you so much.
Thank you, Dr. Walaa, for your presentation. And if there is any question regarding the presentation, please let us know in the chat box. So I think there's no questions so far. But if there is questions, we will be back to answer them shortly as the presenter will continue with us. So the next presentation will be the Dr. Linda and Dr. Malaz. If you are here, the mic is yours.
Hi, can you guys hear me?
Hello, Dr. Linda. Yes, we can hear you.
Okay, I'll share my presentation. Do I
Yes,
have
please.
access to share it? Okay. You can see my presentation, right? My screen.
Yes, we can see it.
Okay, hi everyone. I'm Linda Ahmed. I'll be presenting a presentation about PRISM study. It's a research about the technology adoption by older adults findings from a PRISM trial. Firstly, as an introduction, there is growing evidence of the benefits of personal computers and tablets use for older adults, including improvements in their cognitive, social, and emotional well-being, improvement in perceived quality of life, in their social support, in their engagement, as well as decrease in their depressive states and feeling of loneliness. There is different models of technology acceptance that have been developed to study and understand the factors contributing to technology adoption for older adults to address most of their related limitations. And most recent studies included factors such as age, education, income, race, ethnicity, gender, experience, self-efficacy, perceived usefulness, perceived ease of use, and technology characteristics. For the research gap, extant theoretical models of technology acceptance were limited in their application to older adults studies, on which models included limited sample representations, with small or non-representative samples for older adults. With lack of specialized technology assessments, where most of the studies fail to evaluate technologies specifically designed for older adults based on their needs. And most of the studies also only measured intention to use a technology or short-term use rather than long-term use and actual adoption for the technology. For our study, as a background, it was a randomized controlled trial launched in 2017 with 150 participants, followed up for 12 months. The study evaluated the PRISM system, and the PRISM stands for Personal Reminder Information and Social Management System. It's a computer-based tool for older adults aimed to improving their social connectivity, procedural memory, and resource access. The study and the whole trial used a usability-focused features where it incorporated longer fonts, simplified designs, and tailored training resources specialized for older adults. The study also included free internet access and education to encourage adoption and to reduce their barriers. The study aimed was to assess the effectiveness and adoption of the PRISM computer system for older adults in improving their social connectivity, reducing social isolation, and enhancing their overall well-being. The research objectives. The primary research objectives was first to evaluate the PRISM system impact on social isolation, social support, and overall well-being, and second, to examine the extent to which the predictors of demographical, psychological, and cognitive abilities predicted mid-term and long-term adoption of the computer system specifically designed for older adults. And secondary objectives were first to assess the usability and acceptance of the PRISM system over time, and also to explore how designs, features, and training influences the adoption and use and sustained use. The methodology. As we've just said, the research was a randomized controlled trial held over 12 months to assess adoption and usage. Participants were age of 65 to 95 years, with mean of 77 and standard deviation of 7.2. They were diverse, at a lower socioeconomic status, and living alone, and most of them reported to have good health. The study had two groups. First, the intervention group, which provided the PRISM system with training, free internet, and educational content, and then the control group that received papers, binders, with equivalent resources like guides and games. The procedures. Firstly, randomization and assessment. Participants were randomized and completed a baseline assessment before system installation. PRISM system installation. The PRISM system, including a desktop PC, 19-inch LCD monitor, and other essential accessories, was installed in participants' home by study personnel. An internet service was provided for 1 year throughout the whole study. Training. Participants received 3 individualized training sessions on using the PRISM. They were also given a user manual and access to a technical helpline. And then for the tracking, each use of PRISM features was sent a log message to a central server, enabling continuous monitoring over the 12-month trial. And for the ethical approval, the study received an institutional review board approval, and all participants provided informed consent. Measures, predictor variables. Firstly, data was collected at 3 intervals. Firstly at baseline, and then at 6 months, and at 12 months. Variables were selected based on theoretical relevance and statistical correlation, with correlation coefficient of more than 0.1 with the outcome variables. And for the outcome variables, the PRISM system adoption was measured at 2 different time points. Firstly, midterm use at week 21 to 23, measured to assess engagement halfway through the trial, and then long-term use at week 41 to 43 at the end of the trial. The study didn't include early term use as an outcome variable because most of the trainings and early learnings was occurring during this period, and the average number of days the PRISM features were used per week was calculated. This is the end part of my presentation, and my dear colleague and friend, Dr. Malaz, will continue with the rest of the study presentation.
Hello, everyone. And thank you, Dr. Nina, for this presentation. So do I have an access to share my screen? Hello? Did you hear my voice?
Yes, we
Hi,
can hear
Dr.
you.
Malaz. Yes, we can hear you.
Okay.
Can you share your screen? Or I
Okay.
think we will ask Dr. Nader to give you access.
Okay, sure. I would see. I have to allow them firstly. Okay, so Linda, if it's possible, you can continue. It's the same presentation, fortunately.
Yeah, sure.
I think I need to set up my computer in order to be able to share it. I need to change the security and privacy. I don't know how to figure this right now.
No, it's all right. I'll share mine, and I'll follow up with you.
Okay. Thank you.
Do you guys see the screen?
Yes, we can see it.
Okay. So first of all, my name is Malaz Ibrahim, and I'm a graduate of University of Khartoum. I'm a part of Indigo One group, and today I would continue discussing the study findings for the PRISM trial. I would talk about the usage trend, analyzing daily PRISM usage across early, mid, and long-term phases. I would talk about factors influencing adoption, exploring technology experience, attitudes of the participants, and acceptance among these older adults, and then the facilitator and barriers, identifying the key facilitators and obstacles impacting a sustained usage. Next slide. So with regard to the demographics and personal characteristics, so the age distribution of the participants was ranged from 65 to 98 years, with a mean age of 76.97 plus or minus 7.3 years. With regard to the gender, so the majority of the participants were female, as the female comprised 79% of the study participants, and the rest of 21% were male. Then, as Linda said, that the majority of the participants were from a low socioeconomic background. So the annual income for the majority of them in 84.67%, they are just earned lesser than $30,000 annually, and only 2.19% earned greater than $60,000 per year. Then for the race and ethnicity, they are predominantly white. They comprising about 60%, and the rest were Black or African American. For the participant general health, the mean score was 3.3, plus or minus 0.85 on a scale of 1 to 5. So the mean or the general health of the participant was rated by a self-reported scale. It ranged from 1, which indicate a poor health, to 5, which indicate an excellent health. So the mean in the study participant was 3.03 with the standard deviation of 0.85. And this indicates that participants generally perceive their health as good, and the standard deviation suggests a moderate variability in health perception amongst the group. Yet the range from 1 to 5 indicates that some participants rated their health as poor, while others rated their health as an excellent. Then for the quality of life, it measured by a QUAL-AD for older adult with cognitive impairment, and it showed an average score of 39, indicating a moderate satisfaction with quality of life. Next, Linda. Okay. Then they measured the personality traits of the participants. They used two standardized skills. The first one is called the Center of Epidemiologic Studies Depression Skills. The abbreviation for it is CESD, and the other one is TIPI Statistics. And this indicates it stands for a 10-item personality inventory scale. So for the CESD score, the mean score is a 9.6. The CES is a self-reported also screening tool, and it's designed to measure symptoms of depression in general population. It composed of 20 questions, and the questions are scored on a 4-point Likert scale. It covered 4 domains: depressed mood, somatic symptoms, interpersonal difficulties, and positive affect. So the total score range from 0 to 60, and any score of 16 or higher is typically used as an indicator of clinically significant depressive symptom, and a score of a 20 and above may warrant further clinical evaluation and assessment for the participant. So for our study, for the PRISM study, the mean score was 9.6, which suggests that participants reported relatively low levels of depressive symptoms. Then for the TIPI, it assesses the personality based on 5 personality traits. The first one is extraversion. So the 5 sub-skills were just rated from 2 to 14 or 5 to 14. So the first one is extraversion, and it shows the mean of 8.74 plus or minus 2.73, and this is a moderate level reflecting a mix of introverted and extroverted participants. Then for the agreeableness, the mean was 12.3, its highest, and it's indicating a highly cooperative and sympathetic group. Then for the conscientiousness, the mean was 12.28, and it highlights dependability and self-discipline in the study participants. Emotional stability show an average or a moderate score of 11.33, and this reflects a mixture between a calmness and emotional distress. Then the openness to experience show a mean of 11 also, and it indicates a moderate openness to new ideas and experiences. Next. Then for the technology experience and acceptance, they measured the general experience with technology in general, which showed a mean of 11.29, and a computer proficiency show a mean of 9.86, and this indicate a moderate familiarity with technology. So most of the participants were show a somehow familiarity with the use of technology. Then for the computer attitudes, they show a higher scores in self-efficacy, and self-efficacy is defined as the confidence in use of computers and the computer interest, which highlight a positive attitude toward computer use. The technology acceptance also was assessed based on the ease of use for the technology and the usefulness scores, and this reflects a strong perception for of the PRISM system. Prior researches on a technology experiences or technology acceptance show that technology acceptance and behavioral intentions, which mainly based on the personality, are the most important factors which are strongly correlated with the technology adoption. Then, next slide. Okay, so this is the most important part, is the usage trend over time. So as Linda said, that they are measure the use of the PRISM computers on 3 periods of time. The early time, which defined as the use in the first 1 to 3 weeks. And this indicates a usage, an average usage of 4.08 days per week, plus or minus 2.21. So the participants were used the PRISM computer from 2 days to almost 6.5 days per week. And this indicates an extensive use during this initial phase, indicating a very strong initial engagement from the participant. Then for the midterm usage, this usage was declined to 3.49 days per week, and this reflecting a reduced interaction over time from the participants. Then for the long-term usage, the long-term at the end of the trial, which at 41 to 43 weeks after the start of the present trial, after the training period itself, and it shows a mean of 3.11 days per week, which indicate further reduction in engagement, reflecting a declining trend, and this highlighting a challenge in sustained use from the participants themselves. This decline over time was statistically significant, and the p-value was lesser than 0.01. Next. Then what are the factors or the predictors for PRISM usage? We have a positive predictors and negative predictors. So the positive predictors were computer self-efficacy, which is confidence with use of computer itself, the emotional stability, and the computer interest. So they are all positively influence the midterm use mainly, and the ease of use also related significantly with a midterm usage. Then the negative predictor were depression, which negatively affected both midterm and long-term usage, and then a computer proficiency, which inversely related to usage. Executive functioning, higher executive functioning scores linked with greater midterm and long-term usage. Then I would further explain this on the next slide. So this a detailed correlation of the predictors. So for the computer self-efficacy, it shows a moderate positive correlation with midterm usage with an R, a correlation coefficient of 0.42. So the R was a coefficient which defined the direction and the strength of the relationship between dependent and independent variables using the regression analysis. So the R of point or lesser than 0.3 is indicated a weak correlation or weak relationship. R between 0.3 to 0.7 indicates a moderate correlation, and R of greater than 0.7 indicate a strong correlation. So 0.42 is a moderate positive correlation as the R is positive. The emotional stability associated with better engagement, the R is 0.36, which is relatively weak relationship. Then the computer interest facilitated increased usage during midterm particularly. The R was also show a weak correlation. The ease of use is directly correlated with usability and adoption itself. So the ease of use not only affecting the usage for the participants, it's not only allowed them to use the computer longer, but it also affects the adoption for the PRISM itself. Then depression negatively correlated with post-midterm and long-term usage, and computer proficiency show an unexpected negative correlation of minus 0.22. It's a weak negative correlation, yet it indicates that those with higher computer proficiency were used the PRISM computers less, and this indicates reduced novelty with these systems. The executive function is the strong predictor for long-term usage success. Next. Then then we would see the predictor for the midterm usage and the predictor for the long-term usage. The predictor for midterm was early. The predictor for early term itself was just the training period. The early term was defined as the first 1 to 3 weeks. So they are not measured the predictors of the early term, or they are not taken as part of. They are not taken seriously as part of the study findings. They are just looking for the predictors of midterm, which are defined as 21 to 23 weeks after the start of trial, or the long term, which is at the end of the trial. So the predictor of midterm was the early term usage, which shows stronger, which is the strongest predictor of midterm engagement. So those who use the computer seriously during the early term phase was those who were able to engage or to continue using the PRISM computers on the midterm period. Then the executive functioning negatively associated with midterm usage, and the gender difference. Women exhibited a higher likelihood of midterm usage than male. Then the predictors for long-term usage was the midterm usage. So the midterm usage was the strongest predictor for long-term use. So those who continue to use the PRISM computers in the midterm period was those who are able to use it for the long term period. Then the computer self-efficacy also showed a positive trend for the long-term use. So those who are confident in their use for the computer were continue to use it till the end of the trial. For the executive functioning, it showed an indirect effect with a negative association. So the executive functioning was no longer had a direct effect, but continued to have an indirect effect for the long-term PRISM use. So all in all, individuals who used PRISM more at the beginning of the trial, those with higher executive functioning, and women are more likely to use PRISM at the midterm of the trial, whereas those who used the PRISM more during the midterm of the trial and those with higher computer efficacy were more likely to adopt the use of the PRISM for the long term. Then next. Okay, so the barriers to adoption was the cognitive challenges, so lower executive functioning associated with decreased PRISM use. And this means that the system design for the PRISM computers and the training may not have addressed all the barriers of use for those with lower executive function. So they just need to modify the computers based on the patient functioning itself. The psychological barriers, depression significantly correlated with reduced engagement, yet depression was not affected the adoption for the PRISM computers. It just affected the engagement over time. Limited engagement, the usage declined over time, reflect user disengagement by time. Okay, the facilitator of adoption. So the early engagement was the strongest predictor for sustained adoption, reinforced the importance of the initial usage of computers. So for elder to be able to continue using the computer, they need to use it from earlier age and above, and till the end of their life. Then the user-friendly design, a simplified interface, and the training effectively reduced the usability barrier, and the computer self-efficacy. So confidence in using the computer positively influenced the long-term use for these computers. Okay, so the best strategies from the study for the computer adoption was early exposure and training, which is critical for promoting engagement and long-term adoption. Tailored usability for older adults. So older adults need to have a system which are accessible and user-friendly for them. So they need to have a simple interface. They need to change the font for them, and so on. Then addressing the psychological barriers is very important by incorporating features to support the elder mental health, like feature or programs to combating depression. Next. All in all, the impact of these computers on well-being. So computers that facilitate communication with friends and family, as well as computers which provides an access to mental health resources, has significantly improved the participant overall well-being. And further research or additional studies are required to explore the relationship between technology adoption and depression itself, as the research should focus on understanding how to better facilitate adoption for individuals exhibiting depressive symptoms. Thank you for your time and attention, and feel free to ask any question and provide feedback.
Yes, thank you very much, Dr. Malaz and Dr. Linda, for the great presentation. And I would like also to thank Dr. Nader and all the team behind the organization, all the coordinator and the telegeriatric research fellowship. I really enjoyed the agenda of today. And Dr. Nader, the mic is yours.
Thank you so much, Dr. Sabri, and all the presenters. These are great presentations. So if there is any questions, please raise your hand or jump in. You can add any comments if you have one. Please share your thoughts. So the last item was about infographic. So I'm going to present that. In the meantime, any questions about the previous presentations? You can use the chat and Dr. Sabri can follow up. So regarding the infographic, so I'm gonna share my screen with you guys and we'll take it from there. So basically you want to, let me move this. To use it to make basically a presentation in one page that can be informative to the reader. And it can be used in different places. Different companies can use it, in advertisement can be used, in presentation like the one just we mentioned. For example, the last topic was about a study that can be summarized in one infographic design. And then you can talk about it and each part can be explained furthermore, but you can highlight the top things about the demographic, about the findings as the results, and maybe the conclusion in one place, similar to the poster idea. So when you go to a conference, you will present your work in one, we can call it slide or poster, one place where you can put all things together so that in one place people can take a snapshot of your work and go home with an idea or take home message. So when you want to use it, you can use examples or some templates already made, or you can create your own. So if you go and search infographic examples, there are a lot of either free or paid services or tools. Canva is one of them. It offers a free version, and also you can upgrade. And there are a lot of other services or tools that you can work to create or design your infographic. So the other way to look at is look with the same search at the images, and you can get an idea about how you designed your own design. So there are different ways, different sizes and different colors and so on. So you can get some ideas about all these designs. So when you want to start, I'd advise you to look for some templates or some actual examples. So for example, here they have around 100, 101 examples of how to design and when to design one of them. So I'm going to go over some of them. So for example, here they talk about the categories. Best ones for the startup, like if you have a company, for example, you can use one for this. You can put rules for your employees, for example. And the other one here about business as well. You want to present here about business model. You can also describe. So you can see it's in one slice. You can divide it into some section here. They divide it into 3 sections, for example, to get the message across. And you can go on along with different other examples. In medicine, we can use it. And the shape can be like this, longitudinal, which is upside, like from up, a tall presentation, or it can be sideways. In sideways, we can use, for example, about using images or using maps. So for example, this about Europe and startup there. If you go down, you can even summarize some of the process that you already did or you plan to do. A process where you can start with some steps. For example, about this fellowship, when we started with a small group, and then we build it on that group, first batch, and then second batch, and batch, and then a third batch, and so forth. So initially, we have a small number, but we increase the number of applicants or fellows in this program, and each one brought some new ideas and so on. So we built on each other. So it was a process in the beginning. and we're still going. The good news about this website, for example, you can download. If I want to copy similar template like this, I don't have to create it from scratch. I can just download this and then edit it so that it can serve my purpose. For you guys, I'd like to go down. I think there's a one where you can design your website, but you can also design a CV or resume. For example, you can outline what exactly you want to express or you want to share or to sell yourself, basically. So I'm gonna show you an example here. Are 10 infographic examples. Here you can use a video to look at them, but here basic categories, visual categories, like you can use small circles, and the idea here about how to process things. The last one of this you can go over is about, for example, this is about comparison between two ideas or two versions, vegan versus vegetarian, something like that. You can use and get your ideas cross. The last one I want to talk to you about is about the resume or CV. But still, you can use timeline, for example. If you are doing a process where you started in one time, you went to the second time. For example, about this program, I can present it as in 2020, we started the first step. In 2022, we did this and we presented how many posters or publications. So I can present about my program like this in a plan, and then I can edit this to indicate how many either posters or articles or mobile application we developed during this process. So this is an example of a CV or a resume in one place. So this person would like to apply for a fellowship, and she is looking for interviews. So she put it bright and in big font that she is interested in some interviews. And here the ideas or the findings or the lights of her resume. So she already finished 3 years of PG in internal medicine, and this is the place where she is graduating from and where she is interested or whatever. She listed them. So in your case, you can put the same items similar to if you had training overseas, you can put your training. If you have research, what did you do in the research? How many abstracts or presentation, oral presentation, for example, and you're passionate about what your image and what you are looking for. You are looking for internal medicine, family medicine, psych, or maybe some fellowship, infectious disease, geriatric fellowship. And you can build that and put it in either Facebook or any social media, LinkedIn, something like that. So to do that, we can go and use Canva, for example. And if you create a new design, you can just edit that. So the best thing is to click on resize, and it will show you some options. So if you click on resize, it will ask you about social media, for example. Click on that, you will have Instagram, you will have TikTok, Facebook. If you go down, I think you will have LinkedIn, yes. Let's say I want to link it, LinkedIn post, and you can go ahead. This is a free version for 30 days. You can say, yes, I'm starting the free one, and then it will show you some example, and you can pick up one of these examples. You can put some of the highlights of your resume, and to build similar to this, you will need the items and maybe some icons on the site. To get the icon, there are a lot of free icons here in Canva itself. Or if you want to go, you can go to this website. It's called Flat Icon, or there are other places where you can find some free icons. So if you click on it, you have a category, you can have a list, you can put or copy paste, download, and use any of these icons in your design. So you can build up your own using Canva. You can use a font to edit the font. You can add some images or background. So it's up to you how you build it up. And you can use this as an example. So you can change the color, you can change the font size and your image and some of the icons. So try to play with it. And there are other tools, but Canva provides a free version you can use, or if you have Adobe, that also is a tool that can be used for designing. So if you play around, maybe you can create your own infographic and then place it in LinkedIn or Facebook and see if you have any response from your other fellows or your friends or colleagues. And hopefully this will help you advertise yourself and sell yourself. Maybe there are some opening somewhere and they are looking for someone with visa, for example, if they need visa, or someone with US citizen, or someone with step 3 or some. So just put all in one place and share it, and maybe someone will come across your page and see if they are interested in you, especially if you are applying, for example, in a coming month, there are some fellowship programs, and they did not fill their spots. So still they are looking. And after March 15, maybe you can also use it to see if there are other places that you are interested in. Any questions? Okay, Saria, go ahead, please. Dr. Saria. Sorry, we have Dr. Safa with us, and she got matched. So please go ahead when you are ready, Dr. Safa Ibrahim. Congratulations.
Thank you so much, Dr. Nader. I'm Safa Usman Badr Ibrahim. I have an MD degree in ophthalmology from Sudan Medical Specialization Board, as well as an MRCS degree from the Royal College of Edinburgh. I relocated to US last year. My plan was to apply for a neuro-ophthalmology fellowship. For me, as an old graduate, it was very difficult to go for the user steps. But Alhamdulillah, I did it. Alhamdulillah, I got matched in the neuro-ophthalmology fellowship here in Houston. Thank you so much, Dr. Nader.
Thank you so much for sharing. So you already did step 1, step 3. Did you do step?
Yes. Step 3, not yet. Not yet. I did 1 and 2 and OET exam.
Excellent.
All in 1 year. Yes.
Perfect. So congratulations. And how did you do with the interview?
Actually, I had applied. I got 3 interviews. I didn't apply for many programs as my plan was for neuro-ophthalmology specifically. It's a highly sophisticated specialty. The competition is high, but Alhamdulillah, I got it.
Excellent. Congratulations. Yeah, I know it's very competitive, and we are very, very happy for you.
Alhamdulillah. Thank you so much, Dr. Nader.
Alhamdulillah. Thank you for sharing your experience.
Thank you.
And I wish you all the best. Keep us posted.
Inshallah. Inshallah, you can suggest for me the topics you would like in ophthalmology specifically.
Oh, sure. Yeah. We'll keep in touch. How long is the fellowship? Is it 1, 2, 3 years?
It's 1 year. Yeah, it's 1 year.
I wish you
But
all the
you can extend it into additional year. Yes.
So my suggestion for you, if you are interested in research, maybe you will have some topics, some ideas, some research, one or more projects. If you can share it with the group here so that some of them interested in neurology, and that can be helping you to get a team that you can divide the task instead of doing it by yourself, as well as it's helping them because they will have an idea and something to do, put on their resume. So
I'm very happy to help.
yes,
Very happy.
thank you so much. Glad to hear that.
Okay, thank you, Dr. Nader.
Okay, thanks for sharing and have a wonderful day.
Inshallah, shukran.
Any other updates or any other questions, comments, suggestions, or new ideas?
Yes, Dr. Nader, if you can let me just, I want to congratulate Dr. Safa, and I want to say to her that the chat is full of congratulations. We are really happy for you, and this kind of news are really pushing us forward. So I wish you all the best and congratulations.
جزاكم الله خيرا. شكرا لكم. Thank you so much. Thank you so much.
Yes, you are welcome.
Thank you. And as Dr. Sabri mentioned, you are an example of someone who is putting an effort to achieve a goal. And no matter, sometimes we are an old grad, and this doesn't matter here in the US. The year of graduation is one hindrance, but you can overcome that if you work hard, if you know what you're doing, and if you match what the other program needs. Because at the end of the day, these programs, fellowship, residency, they want someone who is a hard worker that can achieve the goal of that program. Most of the programs, they want to get the job done, and they want you in the process of doing that to get the training and educate yourself. You will be a self-learner. They are not going to spend a lot of time with you. They want you to self-process the whole thing, the steps. They may push you at the beginning, but they want you to be independent as you go along. You will have seniors if you are in residency, they will show you the way. But when it comes to fellowship, for example, they expect you to know everything. But you can ask questions. But in order to show them that you are matching their expectation, you need to do some steps. You need to, as Dr. Safa here did, step 1, step 2, the English test. You need to show them that you have some experience, you are confident. They can tell from the interview that you are a good match if you are confident. So build some skills so that they can see you as a good individual, that they can trust you with the job that they need to be done. Do you want to add something, Dr. Safa?
No, thank you so much. I just advise all of the applicants to work hard. If no pain, no gain.
Absolutely. Absolutely. So we have some of the fellows in this program. They apply to different fellowships, geriatric fellowship, infectious disease, nephrology, and some of them matched and they spent 1 or more years. Some of them matched first year and then they went back to residency. So you can do the residency backwards. And still we have some in the process. I spoke just to a couple of the fellows in this program. One of them had an interview in one of the geriatric fellowship. They have open spot, so they gave her an interview, and she's also considered an old grad. The graduation year was a few years back. So we hope you do your best and set a goal and work hard, as Dr. Safa mentioned, and hopefully you will match somewhere that you'll find useful for you, and we'll be happy for you whatever you do. If you need any help, we are here for you. Thank you. So this is amazing news, and I'm very, very happy for you, Dr. Safa, and we are wishing you all the best.
Thank you so much.
Thank you. Any other comments, any other suggestions, questions, ideas about the fellowship, about the program?
Yes,
Assalamu
Dr.
alaikum,
Nader.
Dr. Nader.
Yes, please go ahead.
Yeah, I'm sorry to interrupt. And thank you all for the nice presentations and congratulations to Dr. Safa. I'm new to the fellowship and I don't really understand where to start from and what exactly I'm supposed to do. I do have experience in research before joining this fellowship, but I just needed some guidance to start with.
Excellent. Thank you and welcome to the program. So we have similar questions in the past. So we have some recordings for the whole process, but in short, what I want from you is you can go over the website where you can find the app. I think maybe you already did. I'm going to share the screen with you. So if you go to research fellowship, when you log in, you will have the agenda for the meetings, the upcoming meetings, but we have previous meetings. So if you click on any of them, you can go and see what the agenda and the recording for that meetings. You can do the same if you go to the meeting on the left side here, Zoom meeting, and you can search by certain things to figure out if you have a certain question. But I think you meaning the research, like if you want to start a research by yourself or with a group. So if you want, you can click on here, research project, and you can find yourself. We have some open projects ideas. You can add yourself, let's say here you are interested in social interaction and so on. You click on this and you can have some information about that, and you can add yourself. If you add yourself to this, when you go back, so let's say you can add your, and I want to be a leader, abstract submission, for example. So if you go back, it will be listed under your project list. So one of the lists here, social. And if you go to one of these, you will have the number of fellows in this project. For example, here are 7 members. You can contact them. If you scroll down, you'll have their email. So you can create a small WhatsApp group, for example, or any type of communication by email or text or calling them. And then you see how far they went or how far they want to go with the process. For example, someone will be a leader, someone will be a team member of that. You'll divide the task, and hopefully you will have deadline and target where you want to present your work, like a conference, or if it's a manuscript you want to present to publish it, so you want to submit to a journal, for example. If you have new ideas, let's say you want to start a new project from scratch, or you started one but you want to add some team members to that project, so you can add a new project, give it a title, maybe a description. If you know some of the fellows are interested, you can add their names. If you want to add additional information, the stage of the, or what phase, and more information about that. After you're done, you submit it and it will be listed here for the other fellows. And you can do that also in the WhatsApp group. You can ask seniors about how to contact other, like some of the seniors already presented, for example, in some of the conferences. So you want to look at that. And you can go to TGRF publication web page where you can find some of the conferences we went to in the past and present it. So maybe some of these conferences might be of interest to you or your team. If you want to look at previous abstracts, they are listed some of the journals here. So this is one of the ways that you can start research project, or you can get involved in some research projects that are going on. The WhatsApp group, you can join and ask questions, or they can help you develop your skills if you need certain skills. Dr. Sapri, you want to share some of your experience? Maybe he can have an idea.
Well, yeah, thank you very much, Dr. Nader. So I just wanted to share with you, Dr. Nader, there is a comment in the chat box from Dr. Asil that she need a letter of recommendation, and she sent an email and also applied through the application. And the other thing that regarding researches, we presented our systematic review meta-analysis, which was in the last of September, but unfortunately I was not able to tell this news in the previous meetings. So we presented systematic review meta-analysis in the Saudi Heart Association 2024 annual meetings. The title was Safety and Efficacy of semaglutide on heart failure patient with preserved ejection fraction, and it is now submitted to one of the journals. It is under review, and hopefully we got accepted, inshallah.
Thank you so much. Dr. Ahmed, it's a process. You're gonna learn a little bit by a little bit, but do you have a specific question?
That's all right. So far, I got what I wanted to start with. The only thing is, I have already worked on several projects before, and we have one paper that we wanted to apply for publication, and we don't know what the process is. I don't think we can do it through you guys, but maybe, I don't know.
So you already have the manuscript ready?
It's under process.
So you still have your team working on getting the manuscript
Yes.
finished?
Yes.
Okay. Do you need extra authors, other additional people?
We have already 8 authors, for I think it's
Okay.
it's
So
enough so far.
yeah, that's fine. So if you have enough people, I'm asking because some of the fellows here might be interested, but the idea is you can use one of the tools. I'm going to share again with you. So Al-Safir has some tools, but like a journal finder, but there's other what's called Jane. If you go to this website, you just put a summary of the abstract or the few points about your ideas and click on find a journal, and it will list some of the journals and the impact factor, and you can go to their website and see how the process. Some of them will be free to submit, some of them will be paid like fees. Some of them might have discounts or maybe free for certain authors from certain countries, like if you are from category like Sudan, for example, or some Yemen or some countries, they can process the review without payment. Otherwise, some of the journal will cost 1,000, 2,000, 3,000, something like that, to get the article or the journal accept your article in an open journal for other to read. So it's a process, but this is the first step if you want to look at a list of journal that you are interested in. What's your topic about?
It's about CPR-induced consciousness. It's a systemic review.
Okay. So you can, if you have the abstract of that paper, just copy paste it and click on find journal, and it will list some of these for you guys. And you can, one of the author or a couple of you can look at the journals and see which one is perfect for your purpose and with a good impact factor and acceptable or affordable fees.
Inshallah. Thank you so much. That was very nice.
Thank you and welcome again. Any other questions or any other comments? If not, I'd like to thank you, Dr. Sabri, and all the presenters from today's presentation. You did a great job. Excellent. Thank you so much for your help. And I'd like to thank all the people who are presented here or joined the team, the Zoom meeting, and Dr. Safa for sharing with us your success. And I'd like to thank all fellows who will look at this recording in the future. Thank you once again. Have a wonderful day and see you next week. If you have questions, please feel free to contact me using the email, WhatsApp, chat, text, or call. Thank you.
Thank you, Dr. Nader. Thank you very much.
You're welcome.